really shifted towards functional organ preservation, whether it is through non-surgical options or surgical options. That, of course, depends on the patient and various other factors. Yeah. So these are the three important trials. The first was the VA trial, which was the first trial that actually showed the importance of radiation, and that with radiation, with induction chemo followed by radiation, you could actually preserve the larynx and also achieve cure. So this was the first randomized evidence that was presented to the head neck community. This was followed by the EORTC study, which was actually focused predominantly on piriform sinus cancers, and it more or less confirmed the findings of the VA trial. In the 2000s, what happened was that concurrent chemo radiation was in vogue, and the RTOG 9111, which was a multicentric study, lead author Arlene Forestier, they actually then confirmed that adding concurrent cisplatin or platinums to radiation actually improved outcomes even more than just radiation. So these are our three trials, and it's important for every youngster to know the trial schema, to know what the findings was. We'll go very briefly. I'm not going in too much into detail. We'll go very briefly into these. So the VA trial, as you can see here, the trial schema was that in the standard arm, of course, it was laryngectomy followed by adjuvant radiation. The intervention arm, it was induction chemotherapy, 2 cycles, response assessment. And of course, if there was a partial response or a favorable response, the patient went ahead for radiation. A very important result here is that larynx was preserved in 64%. The overall survival was equal in both the arms. And interestingly, the overall response was seen in 85%, which was a very encouraging finding. 10-year follow-up also showed that, the overall survival was not different in either arms, and quality of life, of course, was significantly better in patients with a preserved larynx. Then came the hypopharynx trial. This was done in Europe. Here, if you look at the inclusion criteria, it was untreated stage 3 and stage 4 hypopharyngeal cancers, all of which had to be amenable for a total laryngectomy with partial pharyngectomy, and those who were not amenable were excluded. Bilateral nodal disease was excluded. T2 to T4, N02 and 2B. Important to see in their trial schema was that they didn't take just the partial responders. They actually looked at those patients who showed complete response in each cycle, and only then took the complete responders up for definitive RT. So that was one very important difference between the trial schema of the VA trial and the EORTC trial. They had very stringent inclusion criteria. Obviously, they had learned a little from the VA trial as well. Important here to see is that the larynx was preserved in 42% at 3 years, slightly less than the 64% of the VA trial. Survival in the surgery arm was 43%, whereas that in the chemo arm was 57%. The RTOG, it started actually in 1992, Arlene Forestier's trial. Inclusion criteria here again, stage 3, stage 4, predominantly laryngeal cancers, operable tumors, good performance status. Exclusion criteria was T1 lesions and of course bulky T4 gross cartilage erosion, and that is because large T4s with cartilage erosion, they had been proven from the VA trial to perform very poorly with the induction followed by the radiation protocol. And by this time, we had also had important data and relevant clinical data from Steiner's group showing that T1, T2 laryngeal cancers could be very well treated with transoral laser microsurgery. So this was the inclusion criteria for this trial in the trial schema here. They compared, this was a 3-arm trial, induction chemotherapy versus chemo radiation versus radiation alone. A very important criticism of this paper was that it had no surgical arm, right? Results, as you can see, overall survival was more or less similar across all the 3 groups. Very importantly, larynx preservation was 84% in the concurrent CTRT arm, much higher than induction chemo and radiotherapy arms. This was the first initial publication. Excellent laryngeal preservation rate, non-inferior overall survival, and of course, very importantly, lower incidence of distal mets in the chemotherapy arm. Drawbacks, as I said, no surgical arm included. And here, Primary endpoint of the trial was laryngeal preservation. If you look at the main paper and if you look at the commentary that followed, there is a lot of debate and a lot of questions and rebuttals given about, the what the key endpoints were. Survival was not the key endpoint here, and that I'll elaborate a little further. This is the long-term results, right? This was published, I think, somewhere in 2013. And this gave interesting results, which forced us to relook at concomitant chemoradiation through the microscope. So the prime findings here, chemoradiation still had higher larynx preservation rates and local control as compared to induction followed by RT. Laryngectomy-free survival, however, there was no significant difference. The overall survival at 10 years was slightly more in favor of the induction arm, though this was not statistically significant. And if you can see here, these are the survival curves, and you can see the overall survival here. As the race touches the finish line, the blue line, that is induction followed by RT, slightly shows a survival curve difference with the other two lines, right? Induction having a more favorable survival in the long term. Long-term follow-up also indicated a higher unexplained number of non-disease related deaths, which were most likely attributed to long-term treatment toxicity, most commonly being aspiration pneumonitis. So this gave us a lot of input and information about the late toxicities. This was an RTOG analysis of three important trials, one of which, of course, was the 9111. This was done by MECTE. This, again, is a very important paper when one has to quote the side effects of chemoradiation. And you can see that the side effect, the long-term sequelae, classified either as requirement of a feeding tube at more than 2 years after registration and potential treatment-related death, pneumonia within 3 years. 43% of our patients actually had severe late toxicity. This paper, again, is very important to try and understand the fallacies of the three important trials and how the world had to move forward. So what we can conclude is that there were variable endpoints. Another important thing is translating randomized trials to general clinical practice is often very difficult. And especially since these three randomized trials were performed in the Western world, vis-a-vis vis-a-vis applying them to our population, which has larger disease, higher T grade, higher end stage, may not be directly, we may not be able to directly extrapolate the results to all our patient population. What is the ideal endpoint? All the three important trials were designed to answer the question of larynx preservation. They were not statistically powered to look at survival. So what is larynx preservation rate? Larynx preservation rate actually looks at whether the patient had a laryngectomy or not. It does not take into account disease status and survival. Laryngectomy-free survival, on the other hand, looks at whether the patient is alive without having to undergo laryngectomy. Disease status and functionality is again not accounted for. So hence, both these endpoints, while they are good, while they do give us some information, they are not the ideal endpoint that one needs to look at while conducting a randomized trial for organ preservation. And this was a seminal consensus paper, 2009, and they defined non-functional larynx by these three important things: severe dysphagia necessitating a feeding tube, evidence of pneumonia, and tracheostomy within 2 years. And their key recommendations were to include a composite endpoint of functional larynx in addition to survival and larynx preservation, and they mandated baseline assessment of swallowing, right? So again, this was the Asian consensus, where the group recommends that patients having non-functional larynx or cartilage destruction should be considered for upfront surgical treatment, laryngectomy or larynxectomy followed by adjuvant radiation. So this was how the treatment evolved. Now let us look at the factors that affect response. There are patient factors and there are tumor factors. So patient factors, performance status, presence of comorbidities, and very, very importantly, in a community setting outside of a trial design is the ability to complete a full course of chemoradiation without interruptions. Tumor factors, again, we're going to look at T4 disease and cord fixity. So the VA trial, the RTOG trial, look at their inclusion criteria. Highly fit individuals, they can run a 100-meter dash better than you and me, creatinine clearance, age less than 60 years, again, good adherence to protocol and RT completed more or less 85 to 90% of the time. Look at this real world data, and this is from the SEER database from the USA. Only 1/4 of all patients who underwent chemoradiation could actually complete it in time, and 48% had treatment breaks. This is from the Western world, where supposedly healthcare is better, but this is outside of trial design. 48% treatment breaks. So that is to be kept in mind. T4. The VA trial showed that 54% of T4 cancers actually needed a total laryngectomy, especially those with cartilage involvement and large volume tumors. Having learned this lesson, RTOG had only 10% T4 cancers, and they were selected carefully. Now, this is a slide that I've prepared after going through the uh, follow-up paper of the RTOG 9111. This is by Randall Weber, where they discuss the outcomes of salvage total laryngectomy. Here, you can look at the number of patients with T3 with fixed cord, right? And the number of patients with fixed cord who ultimately landed up requiring a salvage surgery. So you can see that 35% in the induction arm, slightly less, 18% in the chemo RT arm, and 31% in the RT arm actually required salvage surgery. If you put together induction and chemoradiation arms, 44 to 164, that is 30% of patients with fixed cords will end up with a salvage laryngectomy. So that again is a very important factor to consider before you decide to send a patient for chemoradiation. And interestingly, if you look at Steiner's paper, if you look at their results of cord fixity, salvage laryngectomy, actually, if you put together, was required in 13.4% of T2Bs and only 14% of T3s as compared to 30% of the RTOG. So this is a direct comparison for fixed cord chemo RT versus transoral laser surgery. And this is from the year 2000s. This is 20 years back. Add to all this hyperpharynx that has a different disease biology. There's a higher rate of distant metastasis, poor salvage rates, and the VA trial and the RTOG trial were actually looking at larynx. It was the EORTC trial that actually looked at hyperpharynx. So the practice of giving chemo RT to hyperpharynx has been extrapolated from these two trials. There's no proper concrete evidence that chemo RT actually works well in hyperpharynx as well. And I think there is a trial designed at Tata Hospital by Dr. Devendra sir and Dr. Kumar Prabhash sir, where they are looking at induction chemotherapy as a bioselecting agent to take up hypopharynx patients for organ conservation. To add to all this data, subsequent to the advent of chemo-RT was a lot of retrospective literature showing that, for T2s and T3s, surgery actually had an increased chance of survival. This is a paper by Chen, paper by Hoffman, which is very often quoted, that showed that patients with T3 laryngeal cancers, if you look at survival outcomes, chemo-RT versus surgery, there was a significant difference. So this again is food for thought, that are we over treating our patients with organ conservation? Maybe patient selection is the key. What are the methods of assessing pre-treatment laryngeal function? We'll go through very quickly. Most importantly is at least a baseline examination by the SLP, and if required, of course, a FEES and a video fluoroscopy. What are the advantages and disadvantages? The FEES actually gives you a very magnified endoscopic view. It can assess swallowing function even without a food bolus, and it is good for visual feedback in improving swallowing during therapy sessions. Right? Disadvantages are it mainly assesses the oropharyngeal and laryngeal phases. It cannot assess the oromotor phase. And it can't see aspiration during swallow, but it can, of course, identify if there's a protective reflex. Video fluoroscopy, on the other hand, is dependent on radiation. You need a good IR facility, whereas FEES can be done in an office procedure. All phases of swallow can be assessed. It's more useful actually in a post-laryngectomy setting. Disadvantage is being it requires highly specified equipment, which is expensive, and of course, visual feedback not being possible. So mandatory today is assessment of the laryngeal function before you send your patient for organ conservation. And very important tool is the penetration aspiration scale. You can all go through this. There are many tools. This is the most commonly used tool, and a score of 7 or beyond, you would not consider a patient for any organ conservation protocol. A little bit about surgical organ conservation, what's new in literature. And here I'll give you two papers from the Italian group. This was a paper on open partial horizontal laryngectomies, analysis of 85 patients and an attempt at prognostication using the location and extent of the disease. So what they did was is they identified a coronal plane passing through the anterior vocal process, and they classified tumors as being either anterior or posterior. And you can see over here that the 5-year survival outcomes of the entire population, posterior tumors, all the various parameters were much lower than those which were anterior. And actually, this location of tumor based upon the vocal process was a better prognosticator than just the T stage. Again, patients undergoing transoral laser microsurgery. This is the same group, 410 patients. Here, the tumor was further subcategorized based on the extent of tumor as assessed on MRI and endoscopic evaluation, often using NBI. And they have tried to come up with new subcategories, right? So out of all these subcategories, what they found was subcategory 5 and 6, where the tumor was involving the anterior paraglottis, as well as if the tumor was going transglottic near the anterior commissure and also involving the preepiglottic space. These tumors were associated with much lower oncological outcomes as well as organ preservation rates. So something new, some food for thought while selecting our patients, even for surgical organ conservation. This ASCO guideline, again headed by Arlen Forestier, is a much needed read for every resident and for every youngster. Tumor factors, low rate of vocal cord fixation, supraglottic tumors, and no cartilage invasion. These are the best tumors to take up. T4 cancers and transglottic deeply infiltrated T3 glottic tumors may not do so well with the organ conservation approach. A dysfunctional larynx, of course, is a big no for organ conservation, and you need to assess the ability to adhere to the treatment protocols, because not all of our patients will be treated in the trial design. So that was my final slide, and thank you for your patient listening.
Thank you, Dr. Harsh. As usual, again, you have given a very wonderful, concise, and informative presentation. Now, I think we'll move on to our case discussion. For case discussion, I would like to invite our examiners and moderators, Dr. Alok Thakkar, who is the professor and head ENT and head and neck surgery at All India Institute of Medical Sciences, Delhi. Dr. Vishal Rao, sir, who is director and consultant head and neck surgery, SCG Bangalore. Dr. Ratan Shetty, he's assistant professor head and neck surgery, ACTREC, Navi Mumbai. And Dr. Mohammad Abdul Karim, he's assistant professor of ENT Oncology, National Institute of Cancer Research and Hospital, Dhaka, Bangladesh. I would also like to introduce our presenter, Dr. Achyut Panuganti from AIMS Rishikesh. He'll be presenting the case on laryngeal cancer now. Dr. Achyut.
Sir, good evening, sir.
Hi. You can start the presentation now.
Yes, sir.
Are the examiners present over here? Alok sir, Vishal sir? I think.
Yeah, yeah, hi. Thank you.
Hi, Alok Thakkar here. I'm available. Yes. Quite enjoyed the talk by Dr. Dhar. Great talk there.
Thank you, sir. Nice to see you, sir.
I think we can start with the case presentation now.
Yeah. Can I share my screen, sir?
Sure, please do that.
I'm sorry, sir. Just a minute. Just a second, sir.
No issues, no issues.
Achyut, if you do not have any videos, then you can just make the presentation.
Yes, sir.
Is there any trouble logging in?
No, sir. Actually, I'm not able to share my screen. That's what I just.
So I think.
So in case you do not have any video, you can just start the presentation.
Now,
I'm very sorry, sir. Can I start the presentation, sir, if it will?
multiple.
Sir, can I just start orally, sir? I have some problem with my system, I think, sir.
I think.
Please start. Please start. That's fine.
Yeah, please.
Very good evening, respected all. I am Dr. Achyut Panaganti, resident in MCH Head Neck Oncology from AIIMS Rishikesh. I'm going to present a case on carcinoma larynx. My patient was tracheostomy, so the patient has given his history in writing, and his wife was present by the side when he was giving history. My patient is Mr. NKD, who is a 51-year-old gentleman from Danchala district of Uttarakhand, who is a graduate and postmaster by occupation. He presented with chief complaints of hoarseness of voice, hoarseness of 1 year duration, and respiratory obstruction of 20 days, for which he underwent emergency tracheostomy on 10th of January this year. History of presenting illness. The patient was apparently asymptomatic 1 year back. Then he developed hoarseness of voice, which is insidious in onset. It progressed gradually. There were no aggravating or relieving factors. It is associated with pain in the throat during swallowing, which is of 3 months duration. It is pricking in type and it is radiating to ipsilateral ear. It is associated with cough for the past 2 months. It is more on taking food more to liquids than solids, and it is progressive in nature. He had severe respiratory obstruction and presented to emergency in Strider, for which he underwent emergency tracheostomy. There is no history of any blood streak sputum, frank blood on coughing, or blood vomitings. There is no history of significant weight loss. There is no history of swelling in the neck or anywhere else in the body. There is no history of any chest pain, bone pain, or pain abdomen. Coming to past history, there are no similar complaints in the past. He is a known diabetic for the past 4 years on medication. There are no other comorbidities or chronic illness in the patient. He has nil significant medical and surgical history, no history of any hospitalization in the past. Personal history is largely unremarkable, with recently changed sleep habits because of tracheostomy. Coming to addiction history, the patient is a former smoker who smoked 15 pack years of cigarettes, stopped five months back. He is a tobacco chewer who has consumed 2 to 4 gutka packets per day for the past 15 years and stopped 5 months back. He consumes alcohol occasionally for the past 15 years and stopped 5 months back. Family history is nil significant. He has no known drug allergies. So with the history, I would like to give the summary. My patient is a 51-year-old gentleman from Uttarakhand who is a former smoker, occasional alcoholic with complaints of hoarseness of 1 year duration associated with odynophagia and referred otalgia, with severe respiratory obstruction, and presented to ER in Strider and underwent an emergency tracheostomy. So probably I'm dealing with the laryngeal malignancy.
So can you be more specific, laryngeal or hypopharyngeal or supraglottis or glottis, and why?
Sir, since the initial symptom of the patient was hoarseness, and he doesn't have any difficulty in swallowing. This is more confined. This is more specific to a laryngeal pathology. And since the patient had hoarseness in the beginning, and it was for a long time, for more over a 1 year period, so probably this might be a glottic carcinoma to start with. Then
why the otalgia?
Sir, maybe the disease might have deep infiltration and reached up to the supraglottis, where the internal laryngeal nerve, through the internal laryngeal nerve afferents and going through the afferents of the Arnold's nerve, the patient might have that referotalgia to ipsilateral sides.
Or the piriform sinus? I agree, could be either.
Sorry, sir?
Sir, or the piriform sinus, the superior laryngeal nerve can be involved in the piriform sinus too.
Yes, sir. In the piriform sinus from the pharyngeal plexus also through the inferior and superior vagal ganglion, it can radiate to the ipsilateral nerve.
Then the patient has, you haven't examined the patient yet. You just told us the history.
Yes, sir. Yes, sir.
Why do you think the patient is having problems with coughing and aspiration?
Sir, probably there might be vocal cord, there might be dysfunctional larynx for which the vocal cords are not compensating in between, and there is aspiration for the patient. So the patient has coughing, violent coughing on taking liquids more than solids.
So that indicates to you a supraglottic or a glottic or a piriform sinus lesion.
So that indicates that the patient might have a fixed vocal cord. So that might be a transglottic malignancy as well, sir.
Certainly, he will have a fixed vocal fold. I agree with you. Anyway, go on. Yes.
Thank you, sir. So on examination, the patient is conscious, coherent, and cooperative, moderately wilt and nourished. His ECOG performance status is 1, and there is no pallor-icterus, cyanosis, edema, or general lymphadenopathy. His vital signs are within a normal limit. And on systemic examination, it is largely unremarkable. Coming to head and neck examination, examination of oral cavity, the mouth opening is adequate with tobacco stained tooth. He has dentate upper and lower alveolus, no loose tooth or no missing tooth. And there was melanoplakia of the buccal mucosa in the palate. There was no suspicious lesion on inspection and palpation. On oropharynx examination of the oropharynx, there were no, it was normal on inspection and palpation. Coming to examination of neck, there was a swelling of 3 into 3 centimeter present in the anterior midline, extending from the level of the thyroid notch till 2 centimeter from the tracheostoma. Swelling is moving with deglutition. The skin over the swelling is normal. A portex cuffed tracheostomy tube of 7.5 millimeters was present with non-fenestrated inner cannula. It was trapped. The peristomal skin is erythematous and inflamed. The neck movements were grossly normal without any restriction from side to side or on extension. There was no lateral neck swelling noticed. And on palpation, the inspectory findings were confirmed. There was mild tenderness present on the swelling. The laryngeal cryptus was present. The skin is pinchable in the swelling area. There were no palpable cervical lymphadenopathy. And the tracheostomy tube was in situ and the air blast was adequate. I have taken this patient for examination of larynx and hypopharynx with 70-degree endoscopy. I could find a growth which was present over the right false vocal cord with ulceration. The extensions of the growth are anteriorly, it is till the base of the epiglottis, posteriorly just anterior to the arytenoids. Medially, the true cords are obscured by the growth. Laterally, it is reaching till the laryngeal surface of the aryepiglottic fold. The right hemilarynx is fixed. The left true vocal cord vision is obscured by the growth, but the left vocal cord is mobile. The glottic chink is inadequate. Bilateral piriform sinus, posterior pharyngeal wall, postcricoid area, interarytenoid area, epiglottis, aryepiglottic fold, vallecula are all free. And examination of nose and ear were unremarkable. So with this, I come to a provisional diagnosis that I am dealing with a carcinoma larynx, which is clinically CT4A, N0 and M0, and subsite is glottis.
Dr. Achyut, Vishal here.
Sir, good evening, sir.
Good evening. Dr. Achyut, I had two questions. One is, would it be correct for you to conclude that it is a carcinoma at this point of your clinical diagnosis? Second, what are the benign tumors that you know of? If you can name 3 benign tumors that are known to affect the larynx and produce similar symptoms that you have seen in this patient.
Yes, sir. I mean, without a biopsy, I cannot come to a confirmation that it is a carcinoma, sir. But most likely, most of the times, the malignancy in larynx in a smoker with a known addiction history, it would be carcinoma. So it might be a carcinoma. And the benign pathology which produces similar kind of symptoms are recurrent
Just
respiratory.
wanted to add here, and I think maybe
Sir.
the other, I think Alok sir and others can guide here. I think it's very important that when you complete your thing, not to give a pathological diagnosis to your case summary before you talk about a biopsy. It's better to talk about the clinical assessment that you are talking about a suspected malignancy in this case based on this history, rather than telling that it is a carcinoma, which you are jumping into.
Yeah,
Okay.
I agree with you, sir. I agree with you.
Can you comment on the other point on, because you've directly jumped into malignancy and you've gone into carcinoma, what are the other things that you should think of at this juncture other than carcinoma when you take it up as a history when a person sits before you? Now we've seen his history, he's come with a tracheostomy. What made you directly? He's got a history of tobacco, so that's okay, but he's also a postman, he's a professional voice user. So what are the things that you can think of which are benign, which can come up like this?
Sir, benign conditions like tuberculosis in India, tuberculosis of larynx, then recurrent respiratory papillomatosis, or sometimes cases of amyloidosis. These can present with laryngeal obstruction and may lead to have a stridor, and then tracheostomy might be done in these cases also.
How
Because
common?
in this case,
Sorry,
he's
sir?
given a history of 1 year in
Yes,
this
sir,
case.
Yes,
So
sir.
now his age, what is his age?
He is 51-year-old, sir.
So juvenile papillomas are ruled out, correct?
Yes, sir. Yes.
Okay, so what are the other things that you can think of with a 1 year kind of a history?
We can think with, if the patient has laryngeal tuberculosis. Sir.
Laryngeal tuberculosis is infected causes. I'm talking about non-cancerous benign tumors. Think about tumor. Now you have taken from a direction of tumor, you are suddenly gone into infection. I'm saying you stick to tumors and tell us 3 differential diagnoses that you can think of in benign tumors of the larynx.
Sir, amyloidosis, sir.
Very rare one. How often do you see amyloidosis?
No,
Anything more commoner?
Sorry, sir.
Okay.
I think
Will
what
you
Dr.
check up
Vishal
and
wants
read?
to. What are the benign tumors of the larynx? That is what Dr. Rao was asking you.
It might be chronic granulomatous conditions that like we have residence granulomatosis or
No, you are again going into inflammation, inflammation out. You only have to stick to us with only benign tumors.
I'll read about this. I'm sorry, sir.
So benign tumors are unusual. Benign tumors may not cause ulceration and may not cause fixation. True, fixation, they may cause restriction of mobility, but you should know what are the benign tumors. In my experience, paraganglioma and schwannoma are the common tumors, and of course the odd salivary gland tumor or adenoid cystic that may come through. Vishal, what's your experience?
Yes, sir. I think I was just wanting him to point out in that direction of differentiating inflammation, infections, and specifically in benign tumors, looking at schwannomas or most commonly neurofibromas. These are not uncommon. Hemangiomas are not uncommon. So these are 3 things that can be coming there, and Achyut, you should divide them into origin from the nerves, origin from the vessels, origin from the muscles. So that way
Yes.
you have a rough direction to say that these are possible. These are the structures that come there. So chondromas can come there because of a cartilage. Schwannomas or neurofibromas can come there because of the laryngeal nerves, or leiomyomas can come there because of the muscles. So and hemangiomas can come there because of blood vessels. So you make a very simple kind of a case to say these are the 4 anatomical structures present there, and any tumor that can come in can originate from this direction. That's just for your understanding to say that you should build a case for yourself.
Yes, yes, yes.
So what are the other paths of referred ear pain that you know of?
So referrotology may be via multiple things, are in the oral cavity through the inferior alveolar nerve, then the buccal nerve, and then through the auriculotemporal nerve, and in the oropharynx through the glossopharyngeal nerve through the Jacobson's nerve, and the internal laryngeal nerve through the Arnold's nerve. So these are other pathways of referrotology in case of
Very
headache.
good. Very good. Thank you.
Dr. Shetty, Dr. Kareem, you want to ask him any questions?
I would like to ask why the patient stopped having tobacco and stopped having tobacco and stopped smoking 5 months back. Did his symptoms worsen?
No, actually, he initially thought of coming to the hospital, sir, but due to COVID pandemic, he would not come. But after that, he is also a learned man. He realized that there is progressive disease, so he said that he thought of stopping someday, so he stopped that.
And may I ask another question? Second question. He underwent tracheostomy 20 days back.
Yes, sir. Yes, sir.
So why was it? What decision was taken regarding his treatment plan?
Sir, see, his imaging was done, sir. We have done a biopsy of that patient. Imaging has been done, and today we operated that patient also, sir.
Okay. Does tracheostomy affect disease-free survival?
Sir, preoperative tracheostomy has there is more amount of loco-regional recurrences with the preoperative tracheostomy. There is.
We'll discuss regarding that later on. Yeah.
Yes.
This is the examination findings.
Yes.
Does referrotology tell you something?
So that there is deep invasion of the tumors, the supraglottis or to the pyriform channels.
Thank you. How do you differentiate between dysphagia and odynophagia?
So dysphagia is basically difficulty in swallowing, sir, and odynophagia is whenever the patient is having pain during the swallowing, sir.
So what question will you ask the patient?
Sorry, sir.
How do you elicit the history to differentiate?
We'll ask whether the patient is having a local pain during swallowing with which he is unable to take liquids. And in dysphagia, we'll ask whether the patient is having straining at taking foods.
And how do you grade dysphagia?
Grading. Sorry, sir. I'll look up.
Yeah, read up.
I have one query, Olaf sir.
Yes, sir.
Chief complaint, change of voice. Okay.
Yes, sir.
Okay. Before you go to clinical examination, what thing keep your mind other than larynx?
Sorry, sir.
Change of voice. Chief complaint, change of voice.
Yes, sir. Yes, sir.
Before go through clinical examination,
Yes.
you usually know that laryngeal pathology causes change of voice. Okay.
Yes, sir.
And other organ other than larynx,
Since the patient is a smoker, sir, any pathology in the lung also in the superior mediastinum, which will affect the pathway of the recurrent laryngeal nerve, that might produce post this.
Excellent, excellent. Another thing is also thyroid.
Thyroid, yes.
Yes, yes. Excellent, excellent. Thank you.
Or esophagus, you could have kept that as a DD2. Esophagus.
Yes, sir. Yes, sir.
Go on then. What else? What did you want to do? What investigations did you do or not do? And
Yes. So after this, I've investigated. I've managed the patient with investigation and further workup. In investigations, for the general checkup of the patient, we have done routine labs, and for the PAC. And as far as the staging of the disease, I wanted to do an imaging in the form of contrast-enhanced computed tomography of skull-based clavicle and screening of thorax and upper abdomen. And later, I would take the patient for direct laryngoscopic examination for disease mapping and biopsy under general anesthesia. With that, I can come down to a histopathological diagnosis and staging of the disease. And later, I can plan the treatment of the patients.
so you can't quite share your screens, but maybe you can tell us all as to what you found on the CT and then what you found in the biopsy. And you predated the CT to you did your CT first and the biopsy later. That's what you
Yes.
were saying.
Yes,
And
sir.
can you tell us why you did that?
Initially, I would like to see the imaging because post biopsy, there might be some information or changes that might change the imaging, sir. So I would like to initially proceed with imaging, then followed by biopsies.
What did you find on both?
Sorry, sir.
What did you find on both?
Yeah, yes.
What did you find?
Sir,
On the imaging?
yes, sir. On imaging, on CCT, on axial section, we could see the heterogeneous soft tissue enhancement, which was present on the right AE fold, right false cord, and it was completely filling both the paraglottic spaces on either side with a narrow airway. The thyroid cartilage was grossly eroded with the tumor, tumor signals present on either side of the thyroid cartilage. And there was gross erosion of the cricoid cartilage, and there was infraglottic subglottic extension also. There was invasion of the thyroid gland anteriorly. However, the skin is free. There were no suspicious lymphadenopathy present on bilateral neck. In the bilateral neck, the posterior pharyngeal wall, the prevertebral fascia was free, sir. And on screening of thorax and abdomen, there were no suspicious lesions which were suggestive of metastasis.
Dr. Achyut, Vishal here.
Yes, sir.
Where do you say is the epicenter of the tumor?
Sir, it was more present
Where did
in
it
the.
originate from?
It is more in the false cord, sir. And it is more present in the paraglottic space, sir, in the ventricle and the paraglottic space.
Now, where did it originate from, do you think, in this entire course of the history and examination that you look at? Where did it originate from, and where is the epicenter of this tumor?
Sir, initially it might have started in the glottis on the right vocal cord. Then it would have progressed to anteriorly towards the anterior commissure and laterally towards the ventricle, and then involving the paraglottic space, and then eroding the thyroid cartilage. And from anteriorly.
In these cases, is there any difference that you see in the patterns of subsites being involved based on the carcinogens that you consume?
Sir, if it is only tobacco, then I think only anterior glottis and the larynx is involved, and along with alcohol, probably the spread is more towards the posteriorly towards the arytenoids and the hypopharynx.
And between types of tobacco?
Between types of sir, tobacco.
In your belt in Varanasi, what is more common there?
Rishikesh, it is BD smoking and smokeless tobacco, sir, in the form of
Correct.
gutka.
And in this patient, what were the habits he had?
He smoked cigarettes, sir, 15 pack years, and he has gutka chewing of past 15 years, sir.
Correct. So he had both of these. So in these
Yes, sir.
kind of things, in an Indian scenario, what is the most common thing that you see?
The patient might have a marginal zone disease also, sir.
Correct. So what is the speciality of this marginal zone? Why do you call this the marginal zone?
So, these are actually present at the zone of transition of the epithelium between the larynx and hypopharynx, sir. So they biologically they are more aggressive tumors, and
What are those epitheliums? Can you tell us?
sir, in the larynx, most of the respiratory surface is lined by the pseudostratified columnar epithelium, and in the hypopharynx, it is stratified squamous epithelium, sir. So when there is transition between these, and whenever the disease starts in this center, then there would be the biologically they are more aggressive when compared to the one which is confined to larynx. I mean,
Why do
any
you call
specific? Sorry,
Why?
sir. Sorry, sir. Please go on, sir.
No. I was just asking, why do you say they're biologically more aggressive? What are the indicators? A, what are the sites that are part of the marginal zone? And B, why do you say they are more aggressive? What happens in these people? How are they different?
Sir, marginal zone, basically it is between the lingual and laryngeal surface of the epiglottis, and secondly on the epiglottic folds. And they are biologically more aggressive because they are sharing two sides at the same time. So they might go into the larynx, or they might spill over onto the hypopharynx to the medial wall of the pyriform sinus. And the nature of the epithelium which is present at the marginal zone by itself is it has more potential for growth. So
So my understanding is it's the erythenoid and the A fold that you get worried about when you call them the marginal zone. And the reason they are more aggressive is because they are likely to be less well differentiated. They may be moderately or poorly differentiated often. And the incidence of lymph node mets is high.
okay, sir. Thank you, sir.
Achyut,
Sir.
Ratan here.
Yes, sir.
What are the findings in this case? In your case, there is a frank cartilage erosion. Otherwise,
Yes.
what are the findings of cartilage invasion on CT scan?
Sir, on CT scan, we can see tumor lysis, we can see sclerosis, we can see gross extra laryngeal spread. Depending on these, we can have a we can tell whether there is cartilage invasion or not.
Okay, you're not sure. Would you like to do some other investigation other than a CT scan?
Sir, if at all we are not sure whether the cartilage invasion we can see properly on CT, then we can go for MR, sir, because MRI has more sensitivity when compared to CT scans.
Which is the most specific, CT or an MR?
Specificity is more for CT scans.
Good. Which is the most sensitive among all these findings? You told sclerosis, cartilage lysis.
Yes, sir.
Disease beyond the cartilage.
Sir, yes, sir. Sclerosis is most sensitive for thyroid cartilage invasions.
And disease on the outer surface of the?
Yes, sir. Disease on the either surface of the thyroid cartilage is
the thyroid cartilage should be the most specific. After
yes,
that, it's sclerosis.
Sclerosis. Okay, sir.
Thank you. If you want to assess paraglottic space or preepiglottic space, what investigation will you?
Sir, paraglottic and preepiglottic space, the fat can be seen even on CT scan, but however, the soft tissue delineation will be much better on MRI, sir. So, if you have any doubt of only involvement of those, then MRI can be done.
And one more question I wanted to ask: how do you define subglottic extension?
So, subglottic extension is defined as extension of tumor from the undersurface of the vocal cords till 5 millimeters posteriorly and up to 10 millimeters anteriorly, sir.
And why
So-
is it 5 millimeters posteriorly and 10 millimeters anteriorly?
Because of the anatomical make of the cricut cartilage, sir, which is
Signet ring shape.
yes, signet.
Yeah, thank you.
But Achyut, I was a bit surprised because when you told us clinically, you did say that clinically this patient had unilateral disease on the right side.
Yes, sir.
You didn't quite mention that there was too much wrong on the right, on the other side. And the other side is mobile also, you said.
Yes, sir. Other vocal cord is mobile, sir. Unfortunately I could not share my screen, sir. But the on findings on endoscopic examination, the disease was more confined to one side, sir. It was more on right side false cord only. But on CT scan, it was like completely eroding the thyroid cartilage on both sides, and it has extralaryngeal spread, sir.
So yeah, that was a bit surprising. You said both paraglottic spaces were involved.
Yes, sir.
What's your
Yes.
clinical finding? Clinical finding, what sites? Subsites and sites.
Sorry, sir.
Clinically, what subsites are involved?
Sir, clinically, on examination, we have tumor which is present in the supraglottis and glottis, sir. But however, subglottic extension could not be seen on endoscopy, sir.
But
because
even
of-
on the supraglottis and glottis, what subsites? Because in the supraglottis, there are 6 subsites, and in the glottis, there are
in the supraglottis,
3.
yes, sir. In the supraglottis, it was supraglottis. It is involving the false vocal cord, and rest of the subsites like ariepiglottic folds, the epiglottis and all were free, sir. And in glottis, we could not see properly because the tumor was like obscuring the view of the glottis, sir, completely.
And you couldn't see the anterior commissure
Anterior commissure not seen, sir.
and contralateral vocal fold.
It was mobile, sir, but however, the true vocal cords could not be seen, sir.
Even on the other side, the false cord was bulging and
Sir, false
shadowing
cord was it was normal on other side. The interarytenoid area, the arytenoids all were having normal mucosa, sir.
so the contralateral arytenoid is normal and mobile, and the contralateral false cord is normal or bulging.
The contralateral vocal cord is mobile, sir, but the false cord was normal, sir.
True cord you couldn't see, or you could see.
But true cord we could not see, sir. Both right and left true cords could not see, sir.
So you don't know about the glottis because you haven't seen
Yes.
it clinically.
Yes.
All you have seen is that there's bilateral supraglottic bulge and the left arytenoid is mobile.
Yes, sir.
And is there any clinical sign of pre-epiglottic space involvement?
Yes, sir. On examination also, there is a 3 into 3 centimeter a smooth bulge present in the laryngeal framework area, which was firm. It was also tender on palpation, sir. So
where was this? Thyroid
this was,
membrane.
yes, at the level of the thyroid notch, sir. From the level of the thyroid notch till 2 centimeters superior to the tracheostoma that we have made, sir.
So there is clinically also sign of laryngeal expansion or laryngeal tenderness,
Yes, sir.
which are indicative of
Which indicative of gross extralaryngeal extension, sir.
there are no lymph nodes.
There are no lymph nodes on examination, sir. I mean, clinically and radiologically, there were no lymph nodes.
What's your final diagnosis, and is there any other investigation you wish to do?
Sir, I would like the patient to be taken for direct laryngoscopic examination for tumor mapping, sir. Then I would take a biopsy. Then my
you did
final.
that?
Sir,
What did you find?
Yes, sir. Sir,
What did you find?
We found that the disease was present in the supraglottis, and posteriorly it was involving the arytenoids, and except for the posterior pharyngeal wall, the bilateral pyriform sinus, it was involving the supraglottis and glottis, sir.
So you had tumor in bilateral supraglottis, bilateral glottis,
Glottis, yes, sir. and subglottis. I mean, today we have
And the hypopharynx?
hypopharynx was complete free, sir. Bilateral pyriform sinus, medial wall of the pyriform sinus bilaterally, and the posterior pharyngeal wall and post-cricoid area were all free, sir.
And one arytenoid was mobile?
Yes, sir. One arytenoid is mobile, sir.
Okay. And did you do a hypopharyngoscopy or a esophagoscopy too?
That we did not do, sir.
Should we? It's a controversial issue.
Sorry, sir.
Should we be looking into?
Yes, sir. Yes, sir. Because on CT scan also there is subglottic extension. So in order to see that there is no cricopharyngeal extension posteriorly and to know the extent of the inferior extent of the disease, we have to do a hypopharyngoscopy and esophagoscopy for this patient.
Yeah, also for possible second primaries. Certainly, if you look at literature from Japan and China, they do say that the prevalence of second primaries in the esophagus is very high, but that is probably a reflection of their endemicity of esophageal cancer in their setups. But even in our situations, supraglottic tumors and hyperpharyngeal tumors or alcohol-based tumors, you need to be a little bit more careful to look at the esophagus.
Yes.
So what should we ask him now, Dr. Kareem Shetty?
Yeah, I have a question. The patient was a tobacco chewer and a smoker since 15 years. I think you should have done a pan endoscopy to rule out synchronous primaries.
Yes, sir. Actually, we have done imaging, sir. Pan endoscopy also should be done.
Include endoscopic procedures?
Sorry, sir.
Does imaging preclude endoscopic procedures to rule out synchronous?
Yes, sir. Yes, sir. Superficial mucosal lesions and they are usually missed on imaging, sir. So direct visualization for mucosal changes should be done, sir.
So you have got a CT thorax along with CT neck, right?
Yes, sir.
Okay. If you have to do one investigation, what investigation will you do among bronchoscopy, esophagoscopy, or a nasal endoscopy? In this case?
In this case, we can do a fiber optic laryngoscopy, sir, and with the superior laryngeal nerve block, we can do the examination of the bronchus also, sir.
I would do upper GI endoscopy to rule out synchronous primary. He was a tobacco chewer. He was swallowing tobacco, isn't it?
Yes, sir. Yes.
What is the
You've done an HRCT chest, no? You've done an HRCT chest. So that is probably good enough for the lungs, but I agree that for the esophagus, there is certainly a case made out. If you don't do it, that's also okay. That's institutional policy, but a case is made out in this situation for having a little bit of a better look at the esophagus.
Sir, in this case, we have done a CECT thorax and upper abdomen, sir. So usually a HRCT thorax would be enough for identifying pulmonary metastasis, but in order to identify lymph nodes in the superior mediastinum and hilar lymph nodes, which might be present along with the second primary lesion of the lung, so we can get a CECT done, sir. In our institute, we do CECT thorax.
Okay.
Thank you.
Especially with subglottic spread of disease.
That's okay. Yes.
So I'd just like to add a point, if I may. So Harsha, for all cases of larynx, I think we should make it a good practice to refer the patient for a voice evaluation and a swallowing evaluation. And also, if you are doing a surgical planning, you might be doing a surgical planning in this case, then to counsel them regarding post-operative laryngectomy free speech. So that I think was missing in your presentation.
Yes, sir.
Actually, in this case, Vishal,
yes, sir.
Now, in this case, let's assume that the patient did not have the extra laryngeal extension, and the patient had a tracheostomy.
Yes,
What
sir.
percentage of the people who go in for organ preservation protocols, that is CTRT, with the tracheostomy would achieve organ preservation? Do you have any data on that?
Sir, if at all the patient initially after the CTRT, if the patient has regained his vocal cords, he would have a better outcome, sir.
No. I'm asking you a specific question. See, this is connected with the previous question which Dr. Harsh asked on why
Yes.
this very important to evaluate preoperatively and assess their speech, their swallow, their breathing,
Yes. Yes.
and have a documentation of this. And he, even in his presentation, very nicely elaborated all the aspects of organ preservation. Now,
Yes, sir.
what you should tell us is, if a person is deemed eligible for organ preservation based on the anatomical features, that means there is no extra laryngeal spread. In
Yes,
such
sir.
an instance, if 100 patients were to be given an organ preservation protocol of CTRT, how many of them would be, you will be able to decannulate at the end of the treatment, and how many of them will still remain with disease or without function?
Sir, almost about 50% of the patients might have a organ preservation after the completion of the disease, sir, and 30% of the patients might go for a salvage total laryngectomy, sir, if it all they complete the initial treatment. And after the induction chemotherapy, as in the trials they have seen, some of the patients might default in the early stages, and after the induction itself, they might have to go for a total laryngectomy, sir.
So do you have any paper that you can quote for this? Any recent papers that you have read that actually gives, that has studied tracheostomy as a prognostic marker for organ preservation?
No, sir. I'll read up, sir.
So it's very important to understand in the spectrum of what Harsh gave in his presentation. If you again go deep dive into the data, see, the data focused mainly on survival, on local regional recurrence and control. But if you can also look at organ preservation and
Yes, sir.
which case, and then you will be able to make better selection pre-operatively on whom to choose for organ preservation, whom to choose for surgical intervention. So
Yes.
please do read up about this from your paper.
Yes.
Alok sir, any
Just-
suggestions on this, sir?
No. I'm happy with the way it's going. I just feel that there's only 20 minutes left for us. So let's look at him from the point of view of how he would be treating this patient and why he has taken the decisions that he has taken.
Yes,
Dr.
sir.
Kareem, you had a point?
Yes, sir. Dr. Achur,
Yes, sir.
can you tell me about peculiarity of anterior commissure of larynx?
Sorry, sir.
Peculiarity of anterior commissure of the larynx. Anterior commissure of the larynx have few peculiarities.
Sir, anterior commissure of larynx, it is attached with the help of Broyles ligament, sir. So whenever the disease is coming up to the anterior commissure, the Broyles ligament will protect it from having a spread. But once the Broyles ligament is eroded, then it will spread superiorly and involve the preepiglottic space, or it will go in anteriorly and involve the inner pericardium of the thyroid cartilage.
Yes, yes.
And it can also involve the other side contralateral vocal cords.
Yes.
And
Supraglottic,
and,
glottic and subglottic are a few distance. That means 2 to 4 millimeter only from anterior commissure.
yes, sir. And people who have involvement of anterior commissure have done relatively bad when compared to people who don't have on surgery with the on transoral laryngeal microscopic surgeries, and also on RT when compared to people who don't have anterior commissure involvement. So.
Excellent.
I think what they say is that the inner perichondrium is deficient where the Broyles ligament is attached, and so if it attaches, if it reaches to the Broyles ligament, it of course can spread up and down along the fibers of the Broyles ligament, but also the chances of cartilage involvement are increased because the barrier to cartilage involvement, that is the inner perichondrium, is missing at the attachment. So finally, after radiology, you have made up your mind that this is a bilateral tumor with this bilateral supraglottic, bilateral glottis, bilateral septum.
Yes, sir.
Yeah, and he already had the tracheostomy.
Yes, sir.
So, and it's obviously involving the cartilage, and it's a through and through involvement of cartilage.
Yes, sir.
Extralaryngeal spread. And one arytenoid is mobile,
Mobile. Yes, sir.
and the cricoid is also involved.
Yes, sir.
So what do you want to do for this patient, and why?
Sir, in this patient, I would like to initially discuss the possibilities with the patient and patient party, sir. And after discussing this case in a multi-tumor board, I would like to take up this patient for curative intent surgery followed by adjuvant therapy. And in the form of
what will you discuss in a board if you have already made up your mind?
I mean, I would like to just take the consensus of the boards that this is a case of T4 larynx and
so you
with
want
the
to
gross
propose
extra.
to the board. You want to propose to the board that you want to do surgery for this patient.
Yes, yes, sir.
So tell us why you make a proposal. The board is here.
Because this patient has gross extralaryngeal spread, the organ preservation might not be better in this patient, and also he has a dysfunctional larynx. So as was seen from the data from the VA trial, that these patients do not do good with organ preservation. So I would like to take up the patient for an upfront total laryngectomy with bilateral neck dissection with or without partial pharyngectomy and TEP insertions.
With or without? I mean, you evaluated, will you or will you not do a partial pharyngectomy?
Sir, as per the DL scopy finding, which is usually done in just before this surgery, proceeding with surgery, the bilateral pyriform sinus are free, sir. So in this patient, he might not require a partial pharyngectomy.
And if the patient says to you that I certainly cannot have a total laryngectomy, it's so disabling, I will not be able to get back to work, how will I support my family?
So if the patient is denying for surgical modality of treatment, then we would send him for concurrent chemoradiotherapy. I mean, for non-surgical organ preservation protocol. In that, the larynx preservation rates are better with the concurrent chemoradiotherapy when compared to induction followed by RT or RT alone. So we would propose
maybe you would
to
try to convince the patient again and tell him what are the factors as to why you've made your call. What we were trying to say to you is that if you're presenting to the board that this is what you want to do, then tell us why you want to do what. So he said that no, I still want radiation, or
okay.
I want non-surgical treatment. So what will you
Then
say?
I would explain the patient that the organ preservation is not possible in this case, and he will ultimately require a salvage total laryngectomy at a later date. And doing a salvage total laryngectomy when compared to upfront is a little morbid procedure, and also his voice outcomes are whatever expectation he has from CTRT or voice, organ preservation might not be present at the end of his treatment. He might not regain his voice, or he might have to end up with a persistent feeding tube or a persistent tracheostomy tube for life.
Achyut, may I ask this question?
Yes, yes.
Achyut, instead of subjecting the patient to chemoradiotherapy, I think you are better served if you convince the patient to undergo surgery, because patient
Yes.
has a cross cartilage erosion.
Yes, sir.
Disease. So what would you do? Would you go ahead with the patient's plan of non-surgical modality?
No, sir. I would like to give him the. I would like to tell him the outcomes of surgery and non-surgical modalities, sir.
Yeah, explain pros and cons of treatment modalities and which best serves the patient.
Yes, sir.
Because his quality of life is function also.
Yes, sir.
What is dysfunctional larynx? What are you looking at dysfunctional?
So dysfunctional larynx basically which doesn't have a serviceable speech when the patient had dysphagia which will require a nasogastric tube, and when the patient has aspiration. So
Serviceable airway. Patient has a tracheostomy tube.
yes, sir. If these are not present, then the patient will have a dysfunctional larynx. And as quoted by Lefebvre, if the patient has admission for pneumonia in the past 1 year, or the patient has tracheostomy tube dependence, or the patient has a NG tube dependence, then it would go in favor of, it would be called as a dysfunctional larynx. So in dysfunctional larynx, opting for a non-organ organ preservation, non-surgical protocols would be unwise. I mean, the outcomes are better with the surgical upfront surgeries when compared to organ preservation protocol.
So basically, you'll say to the patient that you have already lost function, you already have a tracheostomy, you're already not swallowing very well. And even
Yes.
if I do non-organ, even if I do non-surgical treatment, these two things are likely to continue. So if I'm going
Yes.
to operate on you, I give you a better chance of cure. I give you a better chance of relief from your swallowing difficulty and aspiration. And of
Yes.
course, your tracheostomy will stay, but that is likely to stay even if you do non-surgical treatment in this situation.
Yes.
And as the other point that you made was that if we are going to do surgery at a later date, then we can well anticipate a higher degree of complications in that situation, and perhaps a poorer voice outcomes too.
Yes.
Yeah.
Yes, sir.
So Dr. Rao is going to ask you that how will you what are you proposing in terms of his voice outcomes? What are you proposing? What do you want to do for his voice?
Sir, because the patient has a free bilateral piriform sinus which can be closed primarily, and in a upfront case, I would like to motivate him to undergo a primary TEP insertion, sir. So the voice outcomes will be better, and the patient will have less period of voiceless time. So in the primary setting itself, I want to do a TEP, sir. I would motivate the patient in that lines.
And okay, can you tell us how you will manage your surgical margins? What will be the operation that you will do, and what would be the extent of pharyngectomy that you will do?
Sir, in this case, I would like to do a total laryngectomy, sir, and surgical margins would be the same like in open procedures, 5 millimeters away from. In order to achieve a microscopic 5 millimeters margin, I would like to take a clinical margin of about 1 to 1.5 centimeters. But at the same time, I would like to take into consideration that the remnant pharyngeal mucosa, if at all oncologically safe, I would like to preserve it for primary closures.
So what part of the piriform sinus would you include? What part would you not include in the specimen? What part of the
Sir, the medial wall of the piriform, yes, the medial wall of the piriform sinus would be included in the specimen, sir, and the lateral wall and the posterior pharyngeal wall are excluded from the specimens.
So will you elevate the mucosa of the piriform sinus to the lateral wall of the?
Yes, sir. After giving, yes, sir. After dividing the constrictor from the thyroid lamina laterally, I would like to elevate the piriform mucosa. And most of the times, I would like to keep it adherent to the muscle underlying so that it has more strength than normal mucosa.
And the lateral wall of the piriform sinus, which is in relation to the thyroid cartilage.
So because the patient has gross extrathyroidal extension, their extralaryngeal spread through the thyroid cartilage, the oncological margins might be compromised. So I would like to keep it with the specimens.
So both piriform sinus medial wall you will keep with the specimen, and a little bit of the lateral wall too on both sides you want to keep with the specimen.
Yes.
I mean, oftentimes we do raise the mucosa of the piriform sinus on the contralateral side and leave it on the patient to get a wider pharynx to close primarily.
Yes, sir.
And what about the inferior margin?
Inferior margin would be at the level of the in this case it would be at the level of the cricopharynx, sir. And as far as the larynx is concerned, just two rings below the prior tracheostomy that has been done, sir.
So tell us how you would fashion the tracheostoma.
Sir, tracheostomy can be fashioned if at all it is safe, then we will be doing beveling posteriorly so that the posteriors can come superiorly, and we can make a uniformly round tracheostomas. And the size of the tracheostoma, if at all possible, we have to put it more than 1.5 centimeters so that the patient can occlude it with his digits for the phonation.
And any tips to improve phonation? Anything that you can do surgically to improve phonation?
Yes, sir. During my after my excision, I would like to undertake the patient for a cricopharyngeal myotomy, sir, so that the speech in the postoperative period would be tonic. And also the swallowing outcomes are also good with better with cricopharyngeal myotomies.
Achyut, how do you
Yes, sir.
go about addressing the neck? What's neck dissection? What type of neck dissection will you do for this patient?
Sir, since this is a case of N0 neck, sir, I would like to undertake a level 2 to 4 neck dissection, sir, bilaterally, because there is a disease bilaterally present. So, and it is an advanced stage malignancy. I would like to address electively both sides neck, sir, from level 2 to level 4, sir. And also because it has subglottic extension, I would like to clear level 6 also in this case.
Central compartment clearance.
Yes, sir.
And did you resect thyroid lobe on any side?
Yes, sir. Since it has extra laryngeal spread through the thyroid cartilage and also involving the thyroid gland, I've done a total thyroidectomy. I would like to do a total thyroidectomy in this case.
Total thyroidectomy. Did you preserve the parathyroids?
Yes, sir.
Okay. Suppose you preserve one side of the thyroid lobe. What percentage of patients develop hypothyroidism?
Sir, about 22% of the patients after hemothyroidectomy will develop hypothyroidism, sir.
Okay. I think it's more than that.
Okay, sir. I'll just
1/3.
check. 1/3 is.
So let's talk about the voice rehab, and
Yes,
then
sir.
maybe a few minutes about adjuvant treatment after the surgery. So, in terms of voice rehab, what are the options?
Sir, this patient can be offered voice rehabilitation. The tracheoesophageal puncture and voice prosthesis would be a gold standard. But however, if the patient asks for, there are various modalities like electrolarynx, and then we can go for esophageal voice and also TEP, sir. And in TEP, we can counsel him regarding the primary TEP and second stage procedure TEP.
So, what are the pros and cons of each?
Sir, electrolarynx is very easy to learn, and he can regain his voice immediately after surgery once the surgical site has settled in. So, but the problem is like it has a monotonous speech. So, and also dexterity is also always important. The patient has to hold the electrolarynx against the cheek or the base of the tongue. So when it comes to esophageal voice, it is a non-dependent voice where the patient can have hands-free voice. But at the same time, it is a short-lived voice, which will depend on how much of air is able to inject into the upper esophagus. It will not be a monotonous voice, but at the same time, he cannot sustain his voice. But when it comes to TEP, it is a lung-powered speech, which is near normal to the normal voice. So in this, I would like to ask, the patient can also have a hands-free speech with the with having a base plate and a hands-free valve. So if at all he wants a good speech, then I would like to motivate him from TEP only, sir.
Basic advantage is that you can have longer connected sentences, which you can often not get with
Yes, sir.
and of course, intensity and volume can be better. The harmonic
Yes.
to noise ratio can be better. But yeah, it might be. I mean, I'm not so sure we would call it near normal speech.
Okay, sir.
That is the best that we can get at the moment.
Yes.
Dr. Rao may have something to add to that. Vishal, you want to add to that?
Sir, nothing, sir.
So tell us about, you've done the operation and you get a histology which shows that this patient had margins which were more than 4 millimeters, 5 millimeters on each side. And the patient is healed well. It's the day 2022 and the patient is healed well. When would you start the patient speaking and how would you plan subsequent treatment?
Sir, patient in a case of primary TEP, which is done in an upfront case, I would like to start the patient with speaking after he has started orally, and after the oral feeds have started, we'll wait for 2 to 3 days, sir. If there is no visible pharyngocutaneous fistula and if everything is healed, then probably 2 to 3 days after that. So from the time of surgery, it would be in the second to third week of surgery. I would like him to start voice.
And how do you want to look at adjuvant treatment? Post-surgery, this has come as T4 and 2B, pathological stage. Thyroid gland was involved.
Sorry, sir?
Thyroid gland was involved, and this
Yes,
patient
sir.
is staged as T4 and 2B pathologically.
Yes, sir. I would like to tell the patient that he has to undergo adjuvant radiotherapy, sir. Since the tumor is like advanced stage tumor, and by the nature of the tumor itself, he has since it is N2B only, there are no extranodal extension, and there is the margins are also well away. Then I would like to offer him only adjuvant RT, sir.
So, in which situation may you not offer radiation?
If it is a early T3 lesion without any nodes, sir, and with clear margins, where in those cases, in order to have a better voice outcomes and oncologically also it is safe, then I would like to avoid adjuvant RT, sir.
But Achyuta, in this case, wouldn't it be paradoxical? You're saying early disease because you would do laryngectomy for advanced disease.
Yes, sir. Yes, sir.
So maybe sir is asking you for something more specific.
I think it's unusual today not to offer multimodality treatment, but occasionally you might have an elderly patient who has T3 disease and goes into surgery rather than have radiation or chemoradiation. Generally, it's the norm, as Dr. Rao said, that if you do surgery, then these patients are advanced enough to be considering post-op radiation, at least post-op radiation in almost everything.
Yes, sir.
I'm sure everybody here knows the indications of post-op chemoradiation. So Achyut, you seem very well prepared. You have sort of ticked off all the things pretty good. I'm sure you do well in your exam as and when it comes through. It is 7 o'clock. We should be winding up. But if we have the permission of the organizers, then perhaps is there any questions from the people who are who are listening? Then we could look at that. Any
None,
questions?
sir. Thank you. None, sir.
No, perhaps questions from the delegates. We have 50 odd people who have logged in. So maybe somebody wants to ask a question.
Thank you so much, sir.
Thank you, sir. Thank you.
Actually, it was a very good presentation. You were quite well prepared. But I would like to make one point. What happens is whenever we go in for a case presentation or whenever we go in for an examination setting, what happens is we just focus upon the oncology. And so we
Yes,
tend
sir.
to forget about the benign lesions. What are the benign tumors, or what are the inflammatory markers, and all those things. So we have to be careful that we are dealing with the laryngeal anatomical side. So as an anatomical side, what are the different presentations of diseases that may happen there? So we need to have that analysis in mind and not just treat, it's going to be a malignancy. And that's what the examiner also assesses every time you are there in the examination hall. And
Yes, sir.
Harsh has also wonderfully given a chronological history of how the treatment decision has developed over the several years. And that is very important because each article he has quoted has been a landmark in shaping the decision making for laryngeal cancer management. So we should, and all of you must read those articles to develop the understanding and management of the laryngeal cancers. And once again, staging and grading, it's very essential for everybody. I would like Professor Alok Thakkar sir to give any comments about this, any final comments, and then we'll go to Ravi for the thank you note.
Certainly get on their fingertips the indications as to when an upfront total laryngectomy is undertaken and indications when it's not. But in general, I think we tended to cover everything. It would have been nicer if we had seen CT images and could have discussed them rather than just have the report. But I think it's okay.
Thank you, sir. The next presentation will be on the early laryngeal cancers on 24th of February. So we'll be welcoming everybody on that. And now to Ravi, please.
Thank you, Dr. Asim. I would like to thank all the eminent faculties over here today. Dr. Alok Thakkar sir, Dr. Vishal Rao sir, Dr. Kareem and Dr. Ratan Shetty. All of whom are not only eminent faculty, teachers, but as well as perpetual student and academicians. It is wonderful to have you everybody on board, and thank you for taking out your time. Thank you, sir.
Thank you very much.
Thank you.
Thank you very much.
And thank you, Alok sir. Thank you, Vishal sir.
Thank you all. Been a pleasure. Bye-bye.
Thank you, Alok sir. Thank you, Vishal sir.
Thank you also.